Terima kasih. Assalamualaikum warahmatullahi
Thank you. Peace be with you, and may God give you His mercy and His blessings. Shalom, Om Swastiastu, distinguished Mr. Collie Brown, UNODC Country Manager and Liaison to ASEAN, Ibu Lili Pintauli Siregar, Commissioner of the Anti-Corruption Commission, the Corruption Eradication Commission of the Republic of Indonesia. Good afternoon, ladies and gentlemen, distinguished panelists and participants. Welcome to the webinar, Lesson Learned from the Response of COVID-19 Crisis, Recover with Integrity. This event is a collaboration between KPK, the Indonesia Corruption Eradication Agency, with the UNODC to commemorate the International Anti-Corruption Day on the 9th of December 2021. This is also to reiterate about the importance of the effort to prevent and address corruption in healthcare sector, since this sector impact the general public and is very relevant to our common challenges nowadays, which is the COVID-19 pandemic. Before I continue with the event, I would like to ask the host to introduce the interpretation module. Thank you, ladies and gentlemen. This webinar is equipped with the interpretation feature that can be accessed by clicking the globe icon on the bottom part of your Zoom screen. Please click that button and choose Indonesian or Bahasa Indonesia to follow the discussion in Indonesian.
To access the interpretation feature, you can click the globe logo labeled interpretation located at the lower part of your Zoom screen. Click the logo and choose English. You can stay through the English channel throughout the event to listen to the discussion in English. Thank you, and back to moderator.
Terima kasih Pak John. Baik, saya ingin
thank you, John. Now I would like to ask Mr. Collie Brown and Ibu Lili Pintauli to deliver an opening remark as well as a keynote speech. But for the first opportunity, I would like to ask Mr. Collie Brown to deliver his opening remark. Please, Pak Collie.
Thank you. Thank you very much. Thank you, Putri. And good afternoon to everyone. Let me begin by just acknowledging and Ibu Lili Siregar, the Commissioner at KPK, as well as let me acknowledge a few other of the colleagues who are here. Ibu Utami, the Inspector General, Ministry of Health, Mr. Randy Tegu, the Secretary General of Gakislab, Indonesia, as well as we have with our research team who have been working very closely with as well, and colleagues, Mr. Kunto Ariawan from the research team of KPK, and as well as Agus Sarwono from Transparency International, and to all the colleagues who are joining us this afternoon. Today, as you know, we are observing another International Anti-Corruption Day, as we do each year on this particular day. And certainly, I think this day should serve as a day where governments really should submit their scorecards and how well they're doing to prevent and to counter corruption. Unfortunately, we continue to see acts of impunity by various entities and individuals who believe that engaging in corruption is a birthright. The last 2 years have brought increased focus on corrupt practices as the pandemic and the need to save lives has relaxed procurement practices, but unfortunately has also given opportunities to criminals. And yes, that is what they are, who are seeking to benefit and to undermine health outcomes as governments are moving to manage and to control this epidemic. In 2020, the United Nations Office on Drugs and Crime published a policy paper for member states, which really outlined some very specific ways to identify and to mitigate corruption risk related to the manufacture, allocation, and distribution of COVID-19 vaccines. The policy paper also highlights both short and long-term solutions for governments to address the risk in the current pandemic and to increase their preparedness for potential future crisis scenarios. Revisiting this document is critical, particularly today as we are observing International Anti-Corruption Day. Corruption risks certainly related to the manufacturing, the acquisition, and the distribution of COVID-19 vaccines can threaten economies and public health systems worldwide. These risks include the entry of substandard and falsified vaccines into the market, the theft of vaccines within distribution systems, leakages in emergency funding designated for the development and the distribution of vaccines. As well, we can think of nepotism, favoritism, and certainly also corrupt procurement systems. Indonesia is certainly not immune to these risks. And so today's webinars, I think, provides an opportunity for us to examine what Indonesia is doing to recover with integrity from COVID-19 and to discuss the corruption risk and the progress that's being made in terms of mitigation strategies that has been put in place to certainly address this issue. The United Nations Convention Against Corruption and the 2030 Agenda for the Sustainable Development, the SDGs, provides key entry point for member states to recover and to recover better by certainly highlighting several areas, of course, which I believe should be of importance. Prioritizing anti-corruption measures as an integral aspect of all COVID-19 and future pandemic responses, and certainly developing long-term development frameworks to address this issue. Also developing and strengthening and also using and providing access to technology and open data for all sectors to increase social auditing, participation, and transparency, enabling sound decision-making and affording appropriate oversight and accountability, and as well as creating strong legal, regulatory, and policy frameworks and enforcement measures, including transparent, inclusive, and effective emergency response plans. In 2020, the G20 published the G20 Call to Action on Corruption and COVID-19, which consisted of 3 commitments as follows, including promoting transparency in response to COVID-19, maintaining sound governance across the public and private sectors to enhance integrity in our response to COVID-19, stressing the critical role of audit processes and oversight institutions in bringing corruption to light, and certainly promoting integrity throughout our recovery as we strengthen our anti-corruption systems and institutions, using lessons learned from the pandemic to foster stable economic growth and development in the future. This is particularly notable as we observe today's Anti-Corruption Day and as the government assumes the presidency of the G20. These events should serve to recommit strengthening and anti-corruption efforts to ensure transparency in all sectors, holding persons and entities accountable for engaging in corrupt practices. No longer should anyone feel that they can act with impunity. Before COVID-19, I must say that KPK has conducted several studies on corruption risk in the health sector. Certainly, I think the vision of KPK in actually taking on and undertaking this effort even prior to the pandemic. And so I know that in 2020, KPK had conducted over 20 studies on corruption risk related to COVID-19 response and the national economy recovery programs. And so this webinar will certainly discuss these studies and the progress that has been made by the stakeholders on corruption prevention during the pandemic. But this is a critical conversation to have, and I think a timely one. Perhaps some might argue that it might be too late to be having this conversation, but as they say, better late than never. And certainly as we observe today as International Anti-Corruption Day, it certainly is a worthy issue to be addressing. And so I'm pleased that you've all joined us, and we're certainly looking forward to the discussion. And I certainly do, as I close, want to acknowledge and to recognize the partnership that we've had with KPK and with other stakeholders. And we're certainly looking forward to continuing, to expanding, and to strengthening those partnerships. So thank you very much. And over to you, Putri.
Terima kasih banyak. Thank you, Pak Collie, for your remarks. Berikutnya, Ibu Lili, apa kabar, Bu? Selamat siang.
How are you, Ibu Lili? Good afternoon. Now I would like to invite Ibu Lili to deliver an opening remark and a keynote speech to officiate this event. Thank you, Mbak Putri. Peace be with you. And may God give you His mercy and His blessings. Good afternoon. Greetings, everyone. Shalom. Om Swastiastu. Nama Budaya. Greetings of virtue. Please allow me to acknowledge and welcome distinguished Ibu Murti Utami, Inspector General from the Ministry of Health of the Republic of Indonesia, Mr. Collie Brown, Country Manager UNODC, Mr. Randy Teguh, Secretary General of Gakas Lab Indonesia, Ibu Sarah, a global health expert, Bapak Agus Sarwono from Transparency International Indonesia, and everyone who attend this seminar online through Zoom platform. Welcome everyone to this anti-corruption webinar, another collaboration between the Indonesia Anti-Corruption Commission and UNODC. Indonesia is holding the presidency of the next G20 summit, and Indonesia is actively involved in G20 Anti-Corruption Working Group and will chair that meeting next year. In line with the theme that Indonesia proposed, recover together, recover stronger, and recover with integrity. This is actually to ensure that the COVID-19 recovery can take place, can be done well, and can have direct benefit to the people, in a transparent and accountable manner, with integrity and far from conflict of interest. In 2020, G20 call for action on corruption and COVID-19, which consists of 3 commitments: promoting transparency in COVID-19 response, maintaining good governance in public and private sector to improve integrity in COVID-19 response by emphasizing the important points of audit and supervisory agency to identify corruption, promoting integrity during recovery by strengthening system and anti-corruption agencies using the lesson learned from the pandemic to promote sustainable development, economic development in the future. These 3 commitments are the priorities for Indonesia as well as other relevant stakeholders, and we have to support the government efforts to achieve this. This COVID-19 pandemic exposed the risk in healthcare sector, and during a crisis, the emergency procurement system can actually increase the risk. Public health measures and response using state fund is prone or vulnerable to embezzlement and other form of corruption. As a result, the quality of healthcare sector delivered to public will be declined, and KPK also see that healthcare sector is a very strategic sector for corruption prevention as well as public education and campaign for anti-corruption. Since the beginning of COVID-19 pandemic, since the government determined that COVID-19 is an outbreak in Indonesia, the government has paid special attention to this in line with Law Number 19 of 2012. KPK can use its authority to ensure that COVID-19 response budget is spent well through prevention, monitoring, coordination, supervision, including law enforcement measures. Internally in KPK, we have asked all our work units to shift their focus to COVID-19 response and monitoring. We focus on reallocation and refocusing of budget at the subnational level. The prevention unit focus on reallocation and refocusing of budget at the national ministries and agencies, as well as to safeguard the strategic programs like social assistance, vaccine procurement, while the enforcement unit was asked to conduct early detection through oversight mechanism in cooperation with Supreme Audit Agency and the Government Internal Audit Agency. We have also issued circular to all national and subnational agencies for procurement of goods and services, received on how they receive donation and on how to maintain database for the beneficiaries of the social programs. We also ask all the civil servants to work hard because we believe that all of this relaxed mechanism and discretion bestowed upon them can be exercised as long as they do not try to work for their own interest and they can avoid conflict of interest. We also warn everyone not to try to misuse or abuse their authority in this difficult situation, since the perpetrators of corruption during the pandemic will be sentenced with higher sentence. We know that this effort to address the pandemic involve different stakeholders. And now, so far, we have arrested and prosecuted different perpetrators from different backgrounds. And this is actually show our commitment to make sure that we can safeguard the state budget and contribute to public health service. The healthcare service consists of private and public, and we need to have multi-stakeholder dialogues in an open manner on risk of corruption in healthcare sector, and also the COVID-19 economic recovery program, including the corruption mitigation programs that we mentioned before. In this regard, KPK would like to invite all public to help monitor the government programs, because we understand the importance of civil society's role in corruption eradication. And we also launched an application called Jaga, a platform to provide information to public on government programs, for instance, like disbursements of social assistance from government. And at the same time, we can receive public complaints and reports in this platform to be followed up by the relevant units. In observing the International Anti-Corruption Day, and also to support the government effort to recover with integrity, UNODC and KPK organized this webinar, Lesson Learned from the Response of COVID-19 Crisis, Recover with Integrity, as a part of collaboration towards Indonesia G20 presidency, and also to open opportunity for discussion on risk of corruption and also progress in corruption mitigation strategies. In conclusion, KPK has already implemented the three prongs approach: prevention, education, and enforcement by involving community in corruption eradication during the pandemic. This can be translated into various efforts and measures in collaboration and synergy with all relevant stakeholders, because, of course, again, KPK cannot work alone. The support of all stakeholders, as well as the contribution from the general public, is key to prevent corruption and to allow us to detect and identify any abuse and misuse in COVID-19 response. Lastly, KPK continuously open for inputs from various stakeholders to improve our effort to eradicate corruption, including in today's event. We warmly welcome this discussion and brainstorming with various stakeholders to exchange ideas and to evaluate together what have been done. KPK will be more than happy to share our experience, success stories in prevention and eradication of corruption. And we are open to new ideas to improve the effectiveness and efficiency of our anti-corruption measures. These corruption eradication measures should be done collectively by all stakeholders so that we can promote business practices with integrity. This is the end of my remark. Again, thank you very much for all the panelists, the resource persons, and everyone in the audience. I wish you a successful webinar. Allow me to end by giving you a poem. Eating chips by the paddy field. Thank you and greetings.
Waalaikumsalam warahmatullahi
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Ibu. This is my first time hearing a rhyme from you. Thank you for the opening remarks, ladies and gentlemen. Allow me to introduce our keynote speakers.
Beberapa narasumber yang
We are very happy to welcome our keynote speakers who are willing to share their experience with us in anti-corruption efforts in health sector. First is Bapak Kunto Ariawan, the head of the KPK Task Force for anti-corruption during pandemic. He is an auditor, has CFE certification, among others. He previously served as an auditor for 13 years. Next, we have Bapak Randi H. Teguh, Secretary General Gakeslab Indonesia. Gakeslab is an association of lab and also health equipment in Indonesia. The mission of this organization is to encourage the members to become professional, integrate, and also improve the capability of the members. Improving communication with government is also one of the objectives of Gakeslab. And Gakeslab is an active member of an organization called Profit. And next, we're going to hear from Bapak Agus Sarwono, researcher for Transparency International Indonesia. And since the start of the pandemic, along with a coalition of CSO, active monitoring the management of COVID-19 pandemic, starting from the procurement of health equipment and also the provision of health assistance, along with CSO and also Lapor COVID-19 network, currently doing the monitoring on vaccination program. Last but not least is Ms. Sarah Steingrüber, is a consultant of global health based in Berlin, German, and her works mainly focus on anti-corruption, transparency, and accountability in health sector. And Sarah also has experience in the innovation in health sector, access to medications, and health supply health. Sarah is also active in a lot of organization and is an affiliate expert of the U4 Anti-Corruption Resource Center and also Vice Deputy of Health Governance and Transparency Association and member of Working Group on Accountability and Anti-Corruption. That is the profile of our keynote speakers today. Allow me to give the floor to our first speaker, Bapak Kunto Ariawan. Hopefully you're in a healthy condition. The floor is yours, Mr. Kunto.
Di situasi pandemi. Silahkan, Mas.
Ya, terima kasih Mbak Putri. Bismillahirrahmanirrahim.
Thank you, Ms. Putri. Assalamualaikum warahmatullahi wabarakatuh.
Salam sehat, salam sejahtera.
Peace be upon us. May we all in healthy condition. The Honorable Ms. Lili Siregar, KPK Commissioner, Mr. Collie Brown from UNODC, and also the honorable panelists, Bapak Randi. Bapak Randi, I've met you a lot of time and worked together with you a lot. And also Bapak Agus Sarwono, and also Sarah and Ibu Murti, who is unable to join us. Allow me to share you my screen. Thank you. On the first slide,
Jadi di tahun
KPK
2020
in 2020 until 2021, as Ibu Lili has explained before, starting March 2020, we use our resources to monitor the government programs on the management of COVID-19 and also economic recovery. In the monitoring directorate, we are tasked to do monitoring and also assessment on government implementation, and we can provide suggestion for improvement if we find a potential for corruption. In 2020 to 2021, we focus on COVID-19 assessment. Since 2020 until 2021, we have conducted 6 assessments related to COVID-19. Number 1 is on the incentive and for health workers, claims from hospitals, vaccination program, procurement of goods and services in Ministry of Health from 2020 budget year for RDT antigen and reagen, government assistance for vulnerable families, and we see that the budget allocated for these programs is significant, all in trillions, and therefore it requires us to be very careful in utilizing that budget. Related to the incentive of health worker, the biggest issue is that there is a cut in the incentive and also the equal disbursement. The program is a reward given from government to health workers. We already have the criteria and who is eligible to receive such reward. The first problem is the budget. The amount of budget is very limited. Therefore, not all health worker qualified for such incentive. Number one, there is limitation. For example, if one patient is only managed by one specialist doctor and also X number of nurses, the condition on the field is completely different. Therefore, there is a deduction of the incentive because the government need to provide incentive equally. And there are other parties, for example, the hospital management also receiving the incentive intended for the health worker. The second issue is the overlapping of budget. The assessment that I am currently delivering to you, a lot of the issues have improved, but many of our findings we have informed the government and the government have followed up on our recommendation. In the beginning of the COVID-19 pandemic, the central government, the national government, budgeted the incentive, and then the Ministry of Interior Affairs asked the regional government to also do regional government budget refocusing. Therefore, this creates an overlapping incentive, especially for health workers in regions. But with the coordination of the Ministry of Interior Affairs and also regional governments, we have managed to address this problem. The source of budget can come from regional and also national government, but the recipient cannot receive more than one source of fund. Previously, as I have stated before, due to the limited budget in national government, there is a limitation of number of health worker eligible to receive such reward, and support staff, for example, security and also cleaning staff, were unable to receive such incentives. However, the budget from regional government is able to fund the incentive for the supporting roles of this. And the Ministry of Health at that time suggested that there are other people who also support the implementation of health service unable to receive such reward. We sent a letter to Ministry of Health in 2021. We have also revised the regulation to ensure that only people who the health worker managing COVID-19 patients able to receive such reward. In the beginning, university, the interns in hospital, all of the intern receive the incentive, but after that we have improved the process. Another issue that we found in here is the verification process. The verification process starting from the first stage until the ministry level
dulu mungkin Bapak Ibu sekalian pernah melihat bahwa di awal-awal
is quite lengthy. Maybe all of you remember that in the beginning of COVID-19, the disbursement of the incentive took a while. The reason is because there had to be a verification up to national level that the government have to do. We suggested the Ministry of Health to simplify the verification process. For example, Ministry of Health should only focus on a large or regional hospitals, and regional hospitals would be taken care of by regional government. The funding previously from the Ministry of Health then transferred to the regional government, and then the regional government is taking care of the disbursement of the incentive on regional level. However, there was a new challenge. Not all regional government had the commitment to do the budget reallocation for the management of COVID-19. There was a political process to change the use of the budget transferred from Ministry of Health for other purpose. That is the task of our team to encourage regional government to reallocate and refocus the budget for the management of COVID-19. Next. On hospital claims for the reimbursement of COVID-19 services, we found there were several potential that might cause problems. And if you remember, ladies and gentlemen, maybe you have read news that the hospital claims took a while to be reimbursed by the government. Meanwhile, the hospital requires funding for its operational activities, and because there were a lot of services stopped and all the activities focusing to manage the COVID-19 patient, the hospital did not receive income from other services. And the problem was because COVID-19 is a new disease. Each doctor have their own approach and method to cure COVID-19, and in the beginning there was no standard, and the documentation to support the reimbursement of this claim varies. And for example, we have pay for service, and we usually have, and at that time there were different standard on the reimbursement document. At that time, Ministry of Health and also BPJS held a meeting to ensure that the dispute settlement should not happen only at national level, but also at regional. However, because the regional government took a while to establish a dispute settlement team, then the dispute settlement happen on national level. But right now, the regional government already have, some regional governments already have a dispute settlement team. Second, to accelerate the reimbursement, we have fee for service, which is the reimbursement based on the action the doctor taken. But since March or June, based on the latest regulation, we used method
jaminan tenaga kesehatan, klaim terhadap jaminan tenaga kesehatan,
as
jaminan sosial di bidang kesehatan seperti program BPJS, yaitu
used by BPJS program.
CBC ini berarti menggunakan metode paket.
That
Jadi,
means that
paketnya untuk penanganan
we
COVID
have
dan
packages
kesehatan. Sehingga
for
itu
COVID-19 patients,
untuk melakukan
and this
jadinya itu
allow
semakin cepat untuk dapat
standardization of supporting documents, and this would accelerate the time for reimbursement.
apa namanya yang mengganggu rumah sakit.
Another
pada
issue
waktu itu
that affected the liquidity of hospitals was that not all hospitals received the down payment. However, in the Ministry of Health regulation, when a hospital submit reimbursement, the hospital should be able to receive 50% of the total claim after confirmation from BPJS, then they will get the remaining fund. However, not all hospital able to receive such down payment, and at that time we encourage the payment of down payment up to 100%, and later on we would calculate it based on further claims, and this would directly address the liquidity problems. However, this suggestion was not responded by Ministry of Health. Next is there is no certainty in payment. We have recommended to Ministry of Health that they should have an SLA on the reimbursement of this claim. Based on our discussion with several hospitals in the provinces, the hospitals often felt confused as to why the reimbursement claim they submitted later would be paid earlier than the previous reimbursement claim that they have submitted. Next.
Nah, yang berikutnya adalah terkait dengan pengadaan vaksin.
Is related to the procurement of vaccines.
Kita melakukan apa namanya pendampingan. Itu
we have assistance on the monitoring of the whole process of vaccination. In the procurement process, the issue at that time was Indonesian government was planning to get into a contract with a down payment of more than 50% for the purchase of vaccines without emergency use authorization. At that time, we reminded government that the procurement of vaccine without the emergency use authorization has a potential that the vaccine cannot be used. Therefore, at that time, we encourage Ministry of Health on the preliminary stages of the vaccine procurement, we purchased it in limited amount while waiting for the emergency use clearance. We do not want to purchase vaccine which later on cannot be used. And the next issue is the asymmetry of information related to vaccine price, because at that time Indonesia had a weaker bargaining power, and I'm sure a lot of countries were in the same position because the number of vaccines available at that time very limited. At that time, it was difficult for us to understand the price of vaccination sold by vendor to other countries. The reason why we want to know this information is because we want to compare the price we are paying compared to other countries. Based on the data that we receive, the data only comes from Bio Farma. And for the procurement of vaccine in Bio Farma, it was well implemented because it was monitored by various parties, the AGO, Ministry of Foreign Affairs, KPK, INP. All these parties joined the discussion of vaccine procurement.
Vaksin yang diberikan
But what I was saying is that we wanted to understand the price of vaccine vendors sold to other countries. Once the vaccine already arrived in Indonesia, all the process very transparent. And I think for that process, it was well implemented. Of bidding becomes more flexible, like what Bapak Collie stated, and then this would give potential to a conflict of interest. The next potential of the problem is the budgeting. In the beginning of the pandemic, for the vaccine distribution by Bio Farma,
provinsi. Nanti provinsi
the handover happen on provincial level.
Kabupaten dan kota yang ada di wilayahnya.
Regional government would then distribute it to the districts and cities. And using distributors. On provincial level, at that time, we didn't really see a good coordination between Ministry of Health and also the regional government. There were several regional government that did not budget the distribution of vaccine and also had no warehouse to store the vaccine.
COVID-19 sehingga gudang-gudang mereka penuh dengan stok vaksin yang lama. Nah, sehingga ketika datang
when
vaksin
there is when the COVID-19 vaccine needs to be stored, there was no budget to store and also distribute the vaccine stock. And this happened especially during the early stages of vaccine procurement. For areas that are easily reached, for example, Yogyakarta and areas in Java, the price for distribution is not that high. However, outside Java, the price for distribution is higher. Next is on the storage of vaccine.
Ada beberapa daerah yang tidak siap untuk menyimpan vaksin tersebut. Itu memang ada beberapa vaksin yang rusak. Ini juga sudah kita lakukan kerjasama bersama dengan BPKP dan Kementerian Kesehatan untuk melakukan stok opnam terhadap vaksin-vaksin yang ada di Indonesia untuk mengetahui berapa jumlah real yang ada, berapa yang rusak, dan berapa yang disesuaikan dengan catatan yang ada. Itu untuk menghindari adanya penggelapan ataupun penyalahgunaan penggunaan vaksin yang tidak sesuai dengan peruntukannya. Nah, di program vaksinasi sendiri, kita juga mendapatkan informasi terkait dengan jual beli vaksin di salah satu rumah sakit yang ada di Jakarta. Jadi mereka menggratiskan vaksin tersebut untuk tenaga kesehatannya, tetapi untuk keluarga tenaga kesehatannya mereka meminta bayaran jika ingin dilakukan vaksinasi terhadap keluarga mereka. Dan ini sudah kita koordinasikan dengan Inspectorate yang ada di Kementerian Kesehatan. Nah, permasalahan terkait dengan kegiatan vaksinasi ini juga adanya vaksin gotong royong, yaitu vaksin.
A problem related to the vaccination is gotong royong, which is an independent incentive by private sector. At that time, we suggested that the gotong royong incentive implemented after the first and second stages of vaccination and using different facilities. And at that time, one of the issue was that the Ministry of Health, during the distribution to the provincial level, there were several vaccination aimed to specific institutions, for example, political parties or NGO. And I think this is quite weird because they can get their own vaccination. And I think the potential for problem in this is because we need to think about the data. And next is the procurement of goods and services for antigen and reagen. In here, we see there are several potential for problems on procurement and also fraud potential. First, related to the planning, Ministry of Health receive additional budget for COVID-19 around 130 trillion, and this budget, some have been distributed to regional government, for example, for the several equipments have been distributed to provincial government. And in 2021, we have distributed several other budget to allow the regional government to use that budget. However, there are several activities in which the budget is still with under the Ministry of Health. Therefore, the procurement held by the Ministry of Health and then distributed to regional government. We see that there is a big potential of fraud because a centralized procurement is prone to such thing. But for example, for vaccines, the regional government do not have the capacity to do the vaccine procurement. However, for testing, we believe that it can be done by regional government. Next is on the time and also the amount purchased. In the early stages of COVID-19, the test tool purchased in large quantity and the price was not stable. In the beginning, of course, every country require the same equipments, tests, and others. Therefore, the price is very fluctuative. However, in 2020, there was a big purchase, and at that time, the price was so high. And when they were about to be paid, the price of the goods have increased, sorry, have lowered, have changed.
Padahal ketika penerimaan barang untuk
And at that time, there was a question whether the payment should be done according to the earlier agreement or according to the price at that time. And there was an audit. If the vendor could provide a statement on the purchase, then the price that is stated in that statement would be paid. In 2021, we recommend that this problem should not happen during the procurement of antigen and also reagent. The procurement should not be done in large amount because at that time the price was very fluctuative. Next is the procurement method, especially for antigen. We use a catalog for reagent, direct appointment due to the emergency situation we were in. In the e-catalog, the price is not necessarily cheaper because there were flexibilities. And before 2020, the prices on e-catalog would be evaluated by state agency. Vendor would be invited, and also the vendor would do negotiation with LKPP. And vendor at that time also were warned to not sell at a lower price compared to the e-catalog. But since 2021, the price in the catalog is quite similar with the prices in marketplace. And we try to find the cheapest price, and that should be the consideration for ministry when doing the purchase. However, at that time, in Ministry of Health, when they were purchasing the RDT antigen, they did not really do a market survey. Therefore, the purchase that they did when they purchased from e-catalog, there was a gap of 15 to 17,000 of price difference. That amounts to 140 billion in the procurement of antigen. Therefore, we recommended the Ministry of Health to do audit related to this price. And if there is a finding, then we would be able to ask the vendor to justify the price. And if they cannot, they will be asked to return some money to the Ministry of Health. Next, related to the assignment of the SOE. This is quite unique. In June and July, there was an increase of COVID-19 cases in the COVID committee meeting. Kimia Pharma was appointed to create a independent quarantine packages then given to people tested positive for COVID. And the plan at that time, we were planning to do 2 million packages with 200K per package as the price. And because the instruction was verbal, there was no documentation to support that. On the first phase, there was a procurement of 300,000 packages. However, no payment was made yet at that time because there was no approved budget by the Ministry of Health. However, after discussion with Kimia Pharma, and Kimia Pharma requested our support to get the payment done, and then we recommend that they send a letter, CC'd us to do the payment for the first phase. And around 62 billion have been paid for the first phase procurement. However, for the second phase of procurement that we have distributed 300,000 package, the process is still ongoing for the payment. Next, on the independent quarantine packages, there was a change in the medicine for COVID-19 therapy. Earlier, we used oseltamivir.
Itu mengakibatkan
on the second package, we use oseltamivir, which increased the price of medicine by fourfold, while these therapeutic drugs actually comprise of 70% of the cost, and the remaining 30% are the drugs for other symptoms. This is not yet being paid because it is still under the audit of BPKP. Next is on a social assistance program. For social assistance program in 2021, we conducted a study, especially for the conditional cash transfer under PKH, Program Keluarga Harapan, and the non-conditional cash transfer. The first one is about the data of the target beneficiaries. In the past, the data under the Ministry of Social Affairs was very bad. The data was not accurate and was not valid. So oftentimes the data doubles, or there is no the citizenship number uh, of the beneficiaries, and even among different Directorate General in the Ministry of Social Affairs, they have different data. So they call this like different islands. So they are acting as different islands. Since the new minister, Ibu Risma, we combine all of the data. So we use the data that we call the TKS. The TKS that is actually verified with the NIK or citizen ID number. So 20 million data that were suspected to be fictitious were suspended, and we asked the local governments to revise the data, and out of this 20 million, 800,000 data have been revised. The next issue is on the data update. In the previous era, they asked for 1.3 trillion rupiah to conduct the validity validate the data. So we say that that's not the good way to do. Data update should be done by the local governments so that we can save the budget for data updating. Since Ibu Risma's era, this data update task is given to the local government. In the previous minister, only 10 provinces conducted data update, and currently 70% of the district government have already updated data. So they conduct physical check on whether or not the beneficiaries are still eligible, and if so, they update the database. The next issue is the transfer of assistance, especially for non-cash food assistance that can only be used in e-warung using value storing card. The problem is this value storing card. Sorry. So in the past, the fund was transferred directly to the bank account of the beneficiaries. But after the fund is transferred using this value storing card, they cannot find the beneficiaries. So there's 1.3 trillion fund that cannot be disbursed. And this can create potential loss from the state, especially potential loss of opportunity cost for interest. But at that time, the state-owned bank did not return this undisbursed fund, and only after the BPK, the Supreme Audit Agency, asked them to return the fund, they return. So now we ask the technical guidance to be improved. So after 2 months, if the fund is not being used, then they have to be returned. The next one is the expensive price of the price in Iwarung. This is actually because of monopoly and because of the packages. Sometimes there's only 1 or 2 Iwarung in one sub-district. So the warung can actually dictate the price. And next, there's also intervention from the local government.
Terhadap program BPNT ini. Sebenarnya kan BPNT itu kan sistemnya tuh ya
to actually create packages.
kita bebas belanja apa saja asal
So
untuk
this non-cash food assistance can actually be used for anything.
tetapi ada pemerintah daerah yang cukup kreatif
But some local governments are actually quite creative, and with their social affairs office, they prepare the packages. So the beneficiaries can just swipe the card and they get the entire package. And there's a potential of 120 billion inflated price. And we have mentioned this to the Ministry of Social Affairs, and they plan to change the distribution mechanism, not
yang penting barang-barang yang akan dibelinya itu adalah barang-barang untuk kebutuhan pokoknya. Jadi nanti ada pendataannya barang-barang apa saja yang bisa
so basically we want to make sure that they can buy anything. And for monitoring, we have a classic problem, lack of the facilitator. So it's quite difficult for them to monitor whether or not the e-warungs has been working. And this e-warung have been appointed by the local governments. So it's quite difficult to really monitor them. And at the same time, there was no public complaint mechanism, but after KPK launched the Jaga application, the number of complaint and whistleblowing actually increased, which help us to monitor and supervise the program. So thank you very much. And I would like to apologize for any mistake made in this presentation. Thank you and greetings. Mr. Kunto, thank you very much for this presentation. I really enjoy, and I also noted down all of the information that you shared. Together with us, we already have Ibu Murti, Inspector General from the Ministry of Health. I would like to share her profile. Ibu Murti is the Inspector General in the Ministry of Health Affairs of the Republic of Indonesia, who was appointed in the 1st of February 2019, not long after COVID-19 entered Indonesia and the government policies on COVID-19 response was kickstarted. There are many experience and lesson learned that Ibu Murti can share with us on the challenges and problems in preventing corruption during the pandemic. Before he is the Inspector General, she was the head of the Human Resources Bureau in the Ministry of Health. Good afternoon, Ibu Murti. How are you? I'm good. Hopefully everyone is healthy. For the second presenter, we would like to invite you to share with us about the progress achieved by the Ministry of Health. Kunto mentioned about the efforts in Ministry of Health to prevent corruption in COVID-19 response. Thank you for the opportunity. I am now asked to share our experience in the Ministry of Health on how we do our COVID-19 response. Because we also understand that we need to safeguard all of the process, because we don't want to open opportunity for corruption. For your information, I just want to share that no one ever predicted the corruption. And as the new Inspector General, I was tasked to make sure that the initiatives of the Ministry of Health remain accountable and credible. So before I start, I want to share about our strategies for COVID-19 response. We are responsible for detecting the number of cases, and we also work to increase the tracing and genomic surveillance. And we know that the virus has been has undergone several mutations, and this is also the responsibility of government. And the government and for the healthcare, we have to cover the treatment because because this is actually a pandemic, which is a national disaster, and we also have to prepare and ensure the welfare of the healthcare workers. And if we can still do independent quarantine, we still do independent quarantine at home. But if the situation is actually worse, then, for instance, their oxygen saturation decreased, then they need to be referred to hospital.
And of course, the implementation of vaccination, if we don't do this along with the army and also the private sectors and also other important stakeholders, it is impossible that the government do it alone. Therefore, the vaccination program becomes one of a strategic plan of Ministry of Health. And for behavioral change, we work together with other stakeholders as well. I think it is not interesting if I don't talk about the budget. If we're talking about integrity, corruption, we have to also discuss about money. Ladies and gentlemen, in 2020, the budget of Ministry of Health experienced quite a significant increase, 25.7 trillion. This is not as big as in the 2020. In 2021, in 2021, we received an allocation of 114 trillion. Sorry, I cannot see the numbers from here. And this is the role of Inspectorate General to ensure that the budget is well used. And the biggest budget is for the payment of claims, hospital claims, 59 trillion. And the second biggest is for the procurement of vaccine, 30 trillion. The number is quite significant, and the government have a big responsibility to manage this big amount of budget. Next. I would like to mention that as of 8 December 2021, after the second wave of the increase of cases in June and July this year, we are able to manage the number of new cases, and hopefully during the Christmas and New Year holiday, there would not be a spike in number of cases, and the government is keep on asking the society to be careful and still implement health protocol. And
ini ada 4,2
we
juta
have 4.2 million confirmed COVID cases until the 8th of December 2021, and the death toll is 143,000 people, and we also see a significant decrease of inpatient. The bed occupancy rate is at 3%. And here, I would like to remind everyone that holidays bring a potential for an increase in number of cases. Therefore, it is important for us to keep on implementing health protocols and also maintain our good condition. And ladies and gentlemen, the big budget that I mentioned, in here we see there are 935 network of lab under the supervision of Ministry of Health, and the Ministry of Health are providing reagent for these labs. Mostly owned by the regional government. We are not providing for private lab. We are providing for universities and also regional regional labs, and also assist them to do genome sequencing. We have 935 labs. And this is a network of hospitals. There is quite significant budget, around 60 trillion, to reimburse the health services. And if we look at the 1,011 hospitals, mostly are the regional government hospitals. And if we look at the number of the hospitals, we have around 3,000 hospitals, government and also private owned. 85,000 beds dedicated for hospitals. So we have good capacity, and hopefully the occupancy ratio is not increasing. And this is what I would like to explain on how we have to reimburse the hospital claims of the services provided for the COVID-19 patients. Next. Ladies and gentlemen, this is the second biggest budget for the procurement of vaccine, and Indonesia has achieved a big and quite significant 100 million or 48% of full vaccination. This is still under the target given by the president. We're supposed to achieve 50% of first vaccination and 70% of second vaccination. We have to work together with all stakeholders to ensure the acceleration of vaccination programs. This is the vaccination as of 8 December 2021. Then nobody thought a pandemic could happen. We were not ready to receive a very big amount of budget. And based on our experience, we have created a strategy and we have given assistance and also improving policies. We are involved in compiling policies for vaccination procurement, for government policy, and also Ministry of Health. Second, up until now, we are also providing support for the procurement process, and this is our role to provide assistance to ensure that the price is competitive and that the society get their rights, such as vaccination. And we give support to our colleague in Ministry of Health and also on the provincial level. Of course, we want to prevent moral hazard, and we have to keep on monitoring the implementation and the use of the budget to make sure that it is spent in an effective and efficient manner. Next, ladies and gentlemen, this is our role in consulting and also providing assurances. This pandemic also changed our mindset in the Inspectorate General. We have to be able to be trusted by our partners. And one thing that we were a watchdog, and then
kejadian-kejadian atau risiko ya.
we have to manage the risk, and we start by mapping the risk. And second, another challenge that we are facing during this pandemic is how the changes always happen rapidly. Initially, the vaccination only given to a certain group of population. And right now, there is a development that school-age children able to receive vaccination. And this presents a challenge for us. We have to have a sense of crisis. We have to be flexible, and this pandemic and the mutation of the virus is quite rapid. Therefore, we have to be able to be agile. However, at the same time, we have to maintain accountability. Next. Ladies and gentlemen, we understand that the massive budget allocated to Ministry of Health can should be used with the cooperation of partners, and also, for example, the Ministry of Finance. Ministry of Finance want to ensure that there is no duplication of budget with other ministries. That is the reason why collaboration is important. Second, from the procurement until now, we have to do verification. So we are not working alone. We conducted review, and then other party would do quality assurance. And this is the collaboration. We are collaborating to see the vaccine stock And aside from that, this is also part of the audit effort. We are collaborating with the representative of BPKP in 34 provinces and also the regional inspectorate. These collaborations among inspectorates, we have a monthly meeting or bi-monthly meeting to update the progress. And this collaboration is not, we do this collaboration with a lot of organizations. For example, the Drug Administration. And this is the example of synergy, cross-institutional synergy that we are doing. And also for the assistance, LKPP last year implemented several relaxation for the procurement process, but we have to be careful and also fast in our action. We always give recommendation and we always in consultation with our colleagues from KPK to ensure that we are able to implement these programs well. So this is a table that explains about the synergy between Ministry of Health and
Next. Nah, Bapak Ibu, itu penguatan yang di
Ladies and
luar.
gentlemen, that's actually external strengthening. What about the internal strengthening? We have 38 vertical hospitals and health clinics that are already BLU unit. And we also have internal compliance unit in non-BLU unit. So here we are strengthening the capacity of the management to assist us starting from planning, mapping the risk potentials, and also risk mitigation. So this is actually what we are doing. We are strengthening the capacity of the management to ensure that there is no leakage. So basically, we have to safeguard our regular budget, our COVID budget, because most of the COVID budget are also with this work unit. So we are increasing the role of these units. This is my last slide. Thank God.
Di dalam menjaga sebetulnya ya, selain kita menjaga di baik kita punya sistem yang baik, tapi kita membuka tadi Pak, saya mendengarkan Pak Kunto ya. Ini 21 Mei kalau nggak salah yang lalu Pak Pahala membuka atau meluncing jaga tapi dengan ada ini baru ya.
Pak Pahala launch Jaga application with a new channel which is Jaga COVID. And I have already received the list of complaints and we have verified many of them. And this is actually part of our ways to recommend to our leadership on policy. So we are opening different channels to allow the government to get inputs from the public. So thank you very much KPK, especially from Jaga COVID for giving us the listing of public complaints. So Ibu Putri, that's actually what we do to safeguard the budget of the under the Ministry of Health. So APIP plays a very important role in safeguarding the budget. And second, when it comes to pandemic, I believe that no one ever expect this pandemic to happen. And this is an important lesson for us, especially on how we can remain agile, but at the same time, we can also maintain our integrity. Of course, I cannot work alone. I cannot go to the storage room of Puskesmas to check their stocks. So this is a very good synergy, a very good collaboration. And we have very good collaboration with APIP, with BPKP, and also Inspectorate and other line ministries, as well as with KPK and LKPP. So our expectation is we can map out the risk from the very first beginning. We can strengthen the risk management. So colleagues at the work unit can come up with mitigation measures. Ibu Putri, so this is the lesson learned during the pandemic. We have to be agile to adjust our strategy to respond to the pandemic. Thank you, Ibu Murti. I noted several key points. First, about the role of APIP and the Ministry of Health to safeguard the COVID-19 response and processes so that it can be quick, it can be fast, but still in the right corridor. And also the importance of collaboration, synergy, and agility among all stakeholders. Especially, you mentioned about the important role of APIP. Kunto also mentioned about how he identified risk in COVID-19 response, and you also mentioned about the importance of risk management committed by an agency, that we need to identify the risk before we can mitigate the risk. Thank you very much. This is actually very important key tech points for all of us. Ladies and gentlemen, now please allow me to invite our next resource persons, Mr. Randi Teguh. He is the representative of the private sector, and he will discuss about what we have learned from the COVID-19 pandemic. I believe there are some positive lesson learned despite this negative situation, but we really want to hear the views of or from the private sector.
Slide paparan kami bisa dibantu ya.
Thank you, Ibu Putri.
Assalamualaikum warahmatullahi wabarakatuh.
Peace be with you, may God give you His mercy and His blessings. Greetings, Om Swastiastu, Nama Budaya, greetings of virtue. Allow me to acknowledge Mr. Collie Brown and thank him, the country manager of UNODC, for initiating this very good event and also inviting us from the Gakeslab. Thank you for Ibu Lili Pintauli, Commissioner from the Anti-Corruption Agency Republic of Indonesia. Ibu Murti speaking in the same event, and I'm very interested with Jaga COVID. We should have known this sooner so that we can actually disseminate this information to our members. And also Ibu Sarah Steinberg, a health expert from Independent Global. I am actually asked to deliver a presentation, but our focus will only on one sector or topic, which is on procurement of health equipments and services. And we hope that this lesson learned can serve as important lessons for all of us. We from private sector also learned a lot from this COVID-19 crisis, and hopefully this presentation can also provide inputs to Ibu Murti Utami, and hopefully our inputs is not seen as an attack, but rather as a constructive inputs, constructive criticism, because you, from your presentation, there is no component on procurement of healthcare equipments. I am from Gakeslab. Basically, we are an association of companies supplying health equipments and laboratorium. We have more than 1,000 members. So most of our members are manufacturer, distributors, importer, exporter, consultant of healthcare technologies, as well as companies that provide after service, for instance, like calibration and maintenance. During the pandemic, we continue or we strive to provide services to the community to make sure that healthcare equipment and laboratory equipments are maintained in terms of the quality, performance, availability, and accessibility. And our discussion today will be based on the terms of reference that we received. So there are three main points, as mentioned by Collie. We first want to promote transparency in a COVID-19 response, especially in the procurement of medical devices and laboratory devices. We want to maintain good practices so that public and private sector can increase our integrity in our COVID-19 response. And the third one, we also want to promote integrity during the recovery using the lesson learned collected so far. So as mentioned by Ibu Lili, our theme is recover together, recover stronger, and recover with integrity, which is a very good theme. And in order to achieve this, of course, we need to actually see this from the preparedness of regulatory framework. This is very important because in our opinion, transparency and integrity has three aspects: the human, the system or the regulation, and the leadership. Next slide, please.
Ya, ini tadi sudah saya sampaikan. Slide selanjutnya, slide.
Oh, I've mentioned this. Next slide, please.
Next slide lagi.
Next slide.
Ya, jadi perjalanan panjang kritis pada pasokan alat standar Indonesia itu dimulai dengan
the crisis in medical devices started from our increase or spike in the need for medical devices and medical supplies. At that time, we identified that local manufacturers were not able to support the demand because 90% were imported. But for mask and PPE, the main problem was with the raw materials. At that time, the government opened up the market for any importers, and no license were applied except from the NPB recommendation. Before, we need to have any recommendation from the Ministry of Health, but with the new regulation, anyone can actually import. So any COVID related devices and supplies can be imported by anyone, even those who are not working in healthcare sector before. So that's the distribution. Even the distribution license can be waived as long as they receive recommendation from the National Disaster Agency. So I quote this news from business.com. The situation can potentially cause many problems because there are many new players who do not understand about medical devices and laboratory devices, and they do not understand how to choose the right products, the right devices, and how to calculate the order, so there is a potential that the products that they have been imported and have been procured cannot be used. Another excerpt from Indonesian Corruption Watch. There's a data that 7 importers of medical devices that actually cause state loss do not have any experience in importing medical devices, and they are not member of the Lab. We don't have the data, but if you have the data, we will be more than happy to actually check what is the impact to the market. Of course, we have unsafe and substandard medical supplies like PPE, and it cause loss of life of our healthcare workers. We were invited by Indonesian Doctor Association to discuss how to identify good quality PPE, good quality mask, because they were also concerned because many of their members were exposed to COVID-19 and deceased or died in the process. And at that time, we told them that medical supplies. So if you ask about medical supplies, a while ago, before the pandemic, you ask us, we will ask you to check the distribution license number and check who is the importer. But during the COVID, there is no distribution license requirement, which means that the product has not gone through the verification and check process by the Ministry of Health. So at that time, Ministry of Health issued a guidance on how to identify WHO standard PPE. Second problem, medical devices and supplies cannot be used because the specification cannot match or does not match the requirement. The next one is price war. They use a nearly expired device with low price, and this actually disadvantage the domestic industry as well as honest importers. So at that time,
PCR ya dan juga antigen. Kami menemukan pada saat antigen itu bahkan harga produksi dalam negeri yang ada
even the national production cost is actually higher than the standard of the Ministry of Health, and as a result, the imported product is actually cheaper than domestic product, which will in turn disadvantage our domestic product, which means that it reduced the competitiveness of our domestic product. So if our objective is to be self-sufficient in medical devices and supplies, this situation will make it harder for us to achieve that. So this is some analysis why this happened and what are some problems in this integrity issue. First, at that time, maybe we had a panic situation. So the government forget to refer to the regional and international best practices because WHO has issued a model regulation that can be adopted. One of the most important part that should be adopted is not waiving the distribution license or license of establishment, known as license of establishment in other countries, especially during the pandemic. Because this is a much safer option, because this way the government can easily trace the movement and the government can actually know who should be responsible and be held accountable. Especially because Indonesia has already ratified ASEAN medical directives with the intention that the government should be able to identify who own the products distributed.
Justru saat itu pemerintah dalam hal ini Kementerian Kesehatan mengeluarkan.
Unfortunately, the Ministry of Health issued the Ministerial Regulation number 7 of 2020.
Bahkan kami belum melihat sampai saat ini apakah sudah ditarik atau
which I don't know whether this has been cancelled or not. This because this can serve as bad precedent in the future, because most likely this ministerial regulation will be used for other products that are not related to COVID-19. In our opinion, Indonesia might only be the only country that do over relaxation until waiving the distribution license, because other countries like Philippines, Thailand, and Malaysia still apply license or registration of establishment, or at least only replace it with certification process. The second cause is there is no so the electronic catalog by LKPP was not working, and instead it is being replaced by offline procurement system under the supervision of BPKP. As a result, the price setting mechanism is not transparent to everyone. The information is not transparent to everyone, while e-catalog is actually a very good mechanism since it provides transparency and equal opportunity for all vendors, suppliers to get information, and also for those who need to access healthcare devices and supplies, they can easily procure it using the price in e-catalog. This LKHP e-catalog was only reopened again for medical devices and supplies at the end of 2020. Before the pandemic, there was only 2 products of PPE. So you can imagine that in the beginning of the pandemic, of course, the 2 distributors were overwhelmed because all hospitals and all healthcare facilities are requesting the PPEs, requesting to procure the PPE from them. But in 2021, now we have around 150 to 200 vendors, but they are not yet included in a catalog. And now gradually we have more and more vendors included in the e-catalog, but still it doesn't mean that it welcomes the domestic producers. One of the impact of offline procurement is the concern of the vendors, because they are afraid that they will be accused of creating state laws. As Kunto said earlier, maybe during negotiation, during the deal, the raw material price was very high, but with time, the price of raw material decreased. So they demand the price to decrease, which of course is a very bad business practice because it creates uncertainty. This situation can also potentially cause bad image of Indonesia in the eyes of investors, because they will see that Indonesian government is not honoring the contract, and it will create the hesitancy among the investors to invest in Indonesia. In the last part, I would like to provide some inputs with all humility, and I hope this can be beneficial for everyone. I would like to propose so that the government can improve the post-marketing surveillance to identify and to rectify all the damages caused by this over-relaxation. And this corrective action should be done in short term, and in long term, we need to have more comprehensive policies. We also need to see the need for new regulation so that we can go together with the global regulatory standards, so that we can anticipate a future pandemic. And we hope that the electronic catalog can be activated. And the marketplace should also pay attention to this.
Ada beberapa hal dari e-katalog elektronik LKPP maupun e-katalog.
We have LKPP e-catalog as well as the sector e-catalog that we should improve, especially to help in price setting mechanism. Later, we can discuss about this in other forum. Next, we hope that we can establish regulations and policies that can support the management of disruption during COVID-19 or caused by COVID-19 that will one day turn into an endemic, including regulation for new products for price analysis and so on and so forth, and also agreement of fair price. And with the very heterogeneous products in healthcare sector, most likely the price can also be very heterogeneous because the raw materials are different. So, for instance, for PCR test, we have informed the government that we have different system, open system, closed system, manual, one process, two processes. So I think it is unwise to actually have a single price because it does not accommodate the variety in technology. Next one, we also need to protect local products and local manufacturers. This is something that we need to do, especially because we already have presidential regulation number 6 to achieve self-sufficiency, because we don't want to overly dependent to imported products in the future. So that's all that I can share with you. Hopefully, this is actually in line with the topic today, lesson learned from the response of COVID-19 crisis. I would like to apologize for any mistake or if I offend anyone, but please believe me that all of this comes from good intention from my side. Thank you very much, Pak Randi. I noted
justru sebenarnya saya pikir tadi relaksasi yang diberikan pemerintah
I initially thought that the relaxation provided by government was a good incentive, but apparently there are other sides to it as well. And I also noted the e-catalog currently being developed is an innovation and still require further development, still an innovation to open a better access and nurture better competition.
Baik, terima kasih banyak.
Thank you, Bapak Randi. We have listened to speaker from KPK, Ministry of Health, and also from the private sector. Now I'm going to give the floor to listen to CSO.
Sore Mas Agus, apa kabar Mas?
Hello, Mas Agus, how are you? Good. We know that our CSO colleague also do monitoring related to the management of COVID-19. Agus, maybe you can explain more about what you have identified and what we can and should improve related to COVID-19 response.
Terima kasih Mbak Putri, selamat sore dan Assalamualaikum.
Thank you Putri, Assalamualaikum warahmatullahi wabarakatuh. I would like to say thank you for the opportunity to join this panel. Thank you, Mr. Collie Brown. and Ibu Murti, Bapak Kunto, and other speakers. Based on the elaboration of Bapak Kunto and previous speakers, we have more or less similar findings. We have mapped the corruption risk in 2020, and we found that there are 3 sectors, and number 1 is on health sector, second is social sector, and last is SME. For health sector, what Bapak Kunto has stated is quite similar to our findings. For example, related to the procurement of goods and services. And also the lack of transparency related to contract is one of the challenge. And I will share my screen. We know that COVID-19 is a threat to global health. A global health index in 2019 mentioned that almost all countries not ready to face pandemic. And learning from the recovery of previous pandemic, we see that there are risks of corruption. And just briefly, ladies and gentlemen, apologies, the audio is a bit patchy. This is the corruption risk that we try to capture. In principle, what we have listened to from the explanation from our colleague in KPK is quite similar. We have a potential for corruption or the risk of corruption on the procurement of goods and services. And for social assistance, it's also the same, similar with what we have heard before. There is a problem in data accuracy. And also data duplication. And for SOE, there is an assistance for micro assistance provided since last year. Again, we are facing a problem on data. And we also have finding on several regions. For example, in Indramayu, for example, one of the requirements to access one of the incentive is to provide a SOE license. And one of the admin staff in district government falsified the document of the establishment of SOE, and learning from previous experiences. We also see that there are several corruption indications, and we see that there is a lack of information. like what Bapak Randy stated, we have an issue in information transparency to public. And allow me to explain my experience. We try to do tracking of procurement in Ministry of Health using sirup LKPP website. The information, for example, on the specification of the project and work, for example, the project location is not detailed. The keyword that we use here is COVID, PCR, swab, rapid test, APD or PPE, and reagent. And we're tracing this from September to November 2020. If we look at the data in Sirup platform, the total is in trillion rupiah. And the biggest budget is on the e-purchasing and direct procurement. There are 17 packages for emergency procurement. And we found that there are 11 packages exceeding 200 million, while the requirement is a maximum number of 200 million. And in 2021, we also tried to track the logistic of vaccination program, and we found 9 when we are using 9 keywords. And based on this research in Sirup LKPP, we found only 33 procurement packages related to vaccination program. 75.8% is on procurement of goods and others. For example, for vaccination campaign. Once again, the information is very limited. We hope that on the procurement of goods and services, especially on 2021, it should not be using the emergency procurement program, because vaccination program should have been planned since last year, so we cannot use the emergency procurement process. To ensure that the procurement is more transparent. And this is what we try to capture from that platform. In 2021, we found only 3 related to vaccine procurement program, and also on the documentation of emergency procurement, there are only 2 processes related to emergency procurement listed in the platform. A good example is in West Kalimantan in 2020. The documentation of emergency procurement conducted by the health division in West Kalimantan was published in their website. And the information very detailed. For example, PPE purchase, the price of the PPE, and where this logistics distributed to. But it was only until August 2020. And in September to December, not yet. It is possible that the West Kalimantan province is no longer tracking such data or publishing it. Once again, the information transparency is very important during the management of COVID-19 pandemic. From CSO, be it the ICW or Transparency International Indonesia, are trying our best to keep on monitoring the COVID-19 response, especially on vaccination. We highly appreciate our colleague in Ministry of Health that they have provided information on the vaccination program, quite detailed information, for example, the information and also distribution per province. However, I think there is room for improvement, such as on the information on the vaccines already disbursed per region and per brand of vaccine, and also the data on expiry date to allow better vaccine disbursement. And we hope that the information on COVID-19 responses are transparent. Now, this is the impact of the relaxation during pandemic. For example, the corruption of PPE in South Sulawesi, and also social assistance package, and also procurement of mask in Karangasem district, and also Banten, and also Riau, suspicions of corruption on the procurement of 3,000 rapid test to in Meranti district in Riau. All of this happened because of the patchy information that we have. Another important issue that we need to pay better attention to is the ease of procurement of goods and service, while also observing the principle of transparency and accountability to allow CSO to monitor the whole process. Especially in vaccination program. Next is there is no information in budget management in an integrated and detailed manner. We, since the beginning, have encouraged the development of budget dashboard. There is a dashboard, but the information is not detailed. We hope that we would have better information on that. And like what Mr. Kunto stated before, the transparency data of social assistance provided to the society and to ensure that the program is received by the intended target. And we see that there are people who are still in need of the social assistance. So related to those findings, here are our recommendations. Number one is to open all relevant information on the procurement of goods and services. We hope that there is an integrated national data on this, for example, on the need of PPE, medications, and others. Second, providing information related to the need of goods and services in real time and integrated manner. And also to provide information on price of goods and services to public and also the contract of procurement of goods and services to allow CSO to do better monitoring on price, provider, and others, because based on our note, there are several providers with experience on the procurement of health equipment. There are people who have no experience in the procurement of health equipment on bidding. And there was a company, a construction company appointed to do procurement for the health equipment. And to close the gap and prevent corruption, there should be involvement from CSO to ensure a good monitoring on the response of the pandemic on national and regional level. We believe that this collaboration between government and CSO, it would close the possibility or reduce the possibility of corruption. That would be all from me, Ms. Putri. Thank you for your kind attention. Waalaikumsalam. Thank you so much, Bapak Agus. I noted several important factors. Number one is on open data on budget to allow us to know the budget on national and regional level for COVID-19 responses and where those budget distributed to. We need a data that can be accessed by society. And also on open contracting data standard, we hope that this would become a milestone for LKPP to keep on developing that. Right now, we can access some data, but not the contract. And hopefully, the development in the future would allow us to monitor that and to also help nurture competition and better transparency. Thank you so much, Bapak Agus. We have three questions, but we are going to invite Miss Sarah. Hello, Sarah.
Hello, good morning.
Good morning, Sarah. How are you?
Very good, thank you.
Thank you for confirming joining us in this webinar.
Of course, thank you for having me.
Ya, silakan Sarah untuk menyampaikan sebenarnya.
Sarah, the floor is yours to explain about the global response and also the potential of corruption. Floor is yours.
Thank you, Ibu Putri. So I hope everyone can see my screen. I have chosen today to speak to you on the topic of the role of corruption in medical product quality, which is something that has been mentioned by the other colleagues throughout the session today, particularly from Parandi. And I wanted to speak to this particularly because it is an issue that has become very important throughout the COVID-19 response. And it is a topic that I have been working on for the past year. But before I go into that, I just want to remind us all about what makes the health sector vulnerable to corruption. We've heard many of the speakers describing that we weren't prepared for the COVID-19 pandemic and that there have been a lot of risks and a lot of vulnerabilities that have arisen as a result of the pandemic. But why is it that the health sector is so vulnerable? And it's not simply because of the pandemic, but it is partly also because there is a moral imperative to provide healthcare. We are obliged from a moral duty, an ethical duty to provide healthcare. So that means, of course, as a country, we cannot simply not invest in our healthcare systems. There's a lot of information asymmetry within the health sector, between patients and their providers, between regulators and companies, between governments and civil society. And throughout the COVID-19 pandemic, the information asymmetry has accelerated. There's much more information asymmetry. So governments are relying on the good word of companies. Regulators are also relying on the good word of companies. Patients are relying on the good word of their governments, and there's a lot of trust that needs to be upheld and maintained. Within the health sector, there's a lot of what we call principal agent problems. So where you have those who are beneficiaries, who are the receivers of services and goods, and those who are the providers of those goods and services. And it creates a lot of interesting power dynamics that are then amplified by information asymmetry. Patients and even governments, as have been described already with regards to the procurement and the challenges in Indonesia in that regard, they're not like normal consumers. And especially during the COVID-19 pandemic, there have been shortages and scarcities of raw materials and finished goods. And unlike with other types of products where you have a selection of different suppliers, in healthcare, your number of suppliers becomes much more constricted. It may even be only one. And so it creates monopolies, which of course are really, really high risk for corruption. Another point, and I think this is particularly relevant for a country like Indonesia, is that health systems are not the same. And within the same country, a health system may not function ubiquitously. So a health system may work very differently in Jakarta versus one of the Far Islands. And even though it is, of course, the same health system, getting supplies and having expertise in a city or another urban area is much, let's say, simpler or less difficult than it is to put it in a more rural area. And then finally, anti-corruption, transparency, and accountability mechanisms in health systems, they may actually be ignored, so they may not be there at all. They may be insufficient, or they may be ineffective. And I'll speak to that a bit more later on when I talk about the zero tolerance approach and a new paradigm shift in thinking about corruption in the health sector. So those are the vulnerabilities, and I've mentioned a bit throughout, but when you add a crisis to those vulnerabilities, what we find happening is that there is an increase in the drivers of corruption. There's a reduction in the restraints. So if we're talking about procurement, for example, there's maybe fewer actual suppliers, and we have to get things going quickly. So the restraints or the protective mechanisms that otherwise might work in a non-crisis situation, we tend to declassify them, and therefore the opportunistic behaviors can increase, the opportunities for corruption can increase. Now, I think it's important, because we find ourselves in this situation, to consider how we define corruption, and particularly how we define corruption in health. And I'll be calling out a bit sort of the industry responsibilities here. I think we're very much in agreement that public officials and those elected officials, they have a responsibility and a duty of care. But I think within the health sector, there is merit in bringing in the private sector to the definition. And the reason I say this is because if we think of health, which we do, as a human right, it is the highest attainable standard of health is a fundamental human right, and that accessing things like medicines and devices and other medical products is part of that right. It is a fundamental element required to achieve the full realization of the right to health. Then if we think about the definition of corruption, the abuse of entrusted power for private gain, and think that health industry, so medical commodities, pharmaceuticals, medical devices, and so on, they are then de facto entrusted with power, or at least they have assumed power. And that they have an obligation to act in the public health interest, and that a failure to do so would be an abuse of their power. And I think that's an important sort of added dimension to the definition of corruption, and particularly so when we talk about issues of medical product quality, which is what I'll speak to you today. And the reason I bring this up, as I mentioned, it's a topic that I've been working on throughout the last year. I think it's also quite relevant for Indonesia for a number of reasons. It was mentioned during the other presentations that procurement has been a challenge, and ensuring quality products has been a challenge, particularly with regards to PPE. But I also think a historical underpinning is, I have read that there were some problematic quality issues in the past in Indonesia. And so this is an issue that has a lot to do with public trust. So a failure to address this issue, or a failure to maintain good practice, might actually contribute to a loss of public trust, which is so vital right now during the pandemic response. And for your information, we have put out, I with U4, have put out a publication on this issue, and I will share the link to this publication for you in the chat. And what I will present is sort of a snapshot of what we have found. Before I go on, I'd like to just quickly define the different terms that I'll be using. The first is a substandard product, which is that which fails to meet the quality standard, specifications, or both. And I should stress that there is no intention. So it may be that a machine or a product, like a raw product that is received, is not at the specific quality or specification that it should be, but it is not intentional on behalf of the manufacturer to create a substandard product. Falsified products, on the other hand, are those that are deliberately or fraudulently misrepresenting their identity, composition, or source. And this is where we find corruption, because it is an abuse of entrusted power. I'd like to just finally qualify this by bringing the definition of unregistered or unlicensed products. And these are products that have not undergone approval or evaluation for the jurisdiction in which they are being distributed, marketed, or used. I'm less concerned as a public health expert on the issue of unregistered and unlicensed products, simply because it doesn't necessarily mean that the product quality is poor. It just means that the sort of supra-level regulatory box ticking has not happened. But when it comes to patient care and good patient outcomes, it's not necessarily the case that these products will be damaging to patients. Whereas falsified products and substandard products, in every case, have the potential to be harmful. And the reason that this is important is because there are a number of consequences, particularly for falsified medical products. And that's what I'll be highlighting as I go throughout now. There's a socioeconomic impact. So if people are not able to be healed or cured of their disease, you have a lost productivity. If they have to continue to purchase medicines that are not of good quality, you have a loss of income. And also because they're not able to go back to employment, there's a lack of social mobility and increased poverty. Illness and disease contributes to increased poverty, and falsified medical products adds another element to that burden. There's an economic impact whereby there's economic loss, there's wasted resources, and there's increases in out-of-pocket spending for those receiving services. But for me, most importantly, we have a health impact. We have higher disease prevalence because people are just not being cured of the ailments that are afflicting them. There's a progression of antimicrobial resistance, which affects us all. There's increased mortality and morbidity because of the adverse effects or the fact that the product doesn't actually do what it's meant to do. And then there's a loss of confidence. And so this can apply to medicines and such, but it can also apply to PPE. If you're working in a health facility and you're already quite nervous about having to engage with patients, and then the PPE that you are receiving is of poor quality, it's falsified, then you will lose confidence in your employer and potentially the health system at large. And that has a ripple effect throughout society. Just to highlight that this is a global problem. This is data from the World Health Organization. They operate a global mechanism to record instances of substandard and falsified medical products. And as you can see, it's everywhere. It's in high-income countries, it's in low-income countries, and it's in middle-income countries. It's not restricted to certain income levels. Now, the research that we carried out, we were able to identify 9 particular drivers of falsified medical products, and particularly that have become amplified throughout the COVID-19 response. And these include supply chain disruptions because of the limited mobility, things like poor stock management, irrational and unauthorized use, maybe misinformation and deception, legislation and policy gaps, and so on. I could speak to all of these, but I would encourage you instead to have a look at the publication, which can provide much more detail, and that way I can sort of move on to perhaps more interesting aspects. For the purpose of the publication, we devised a conceptual model for corruption in falsified medical products. We were able to identify sort of the main players, and I would encourage colleagues in Indonesia to consider sort of who are the major players within the system to be able to then identify sort of where these risks or vulnerabilities might lie. So we have the government or the regulator, we have procurement authority, we have distributors and manufacturers, and then of course we have the providers and our patients. There is a high risk of things like bribery or collusion, of bribery and collusion for things like GMP certification, product approval, for importation, or conflicts of interest between manufacturers, distributors, and regulators. There's also a high risk of bribery and collusion for public tenders to the procurement authorities, which is a very big concern. Not necessarily in Indonesia, and this is not specific to the country, but it is a general concern. Then, of course, there is a concern for the provision of procured falsified medical products to be dispensed by healthcare providers, so that healthcare providers unknowingly, in fact, then dispense, or in fact, knowingly. We have seen many cases of that in which healthcare providers will actually manipulate products to provide falsified ones to patients. There may also be some collusion or bribery between manufacturers and distributors with healthcare providers to actually dispense them as well. Then, of course, there's the direct sale of these types of products through online pharmacy. I'm not familiar with the extent of online pharmacy or the use of social media for pharmacy in Indonesia, but this is a growing area of concern, particularly because of increasing levels of home office and lockdowns and stay-in-place orders and things like that. People are more and more looking to delivery services to provide them with the products that they need, and pharmacy, of course, is one of them. And then finally, there are concerns about the sale or dispensing of falsified medical products to patients directly from healthcare providers again. But indeed, in this regard, it could be that healthcare providers are actually involved in schemes to manufacture them. Now, when it comes to addressing this type of an issue, I'd like to submit to you today a sort of paradigm shift, which is something that I and my colleagues at institutions like the World Health Organization, the World Bank, and the Global Fund have been discussing on how we can start to do anti-corruption better for the health sector. Because as I mentioned, there are quite a number of unique vulnerabilities to the sector. And to do this, I think that there are two really important questions, which is nice because two is a small number of questions. But they're critical, I think, when it comes to thinking about how to address corruption. And I'll relate this then back to the issue of falsified medical products in just a moment. The first question, very simple, is what are the objectives, or what is the objective? What am I trying to do? And in the health sector, our objective is never to do anti-corruption. The objective is to provide better health outcomes, to provide a consistent, quality, affordable, accessible health service. It's never to do anti-corruption. Then the second question is, what corruption is most likely to happen and will cause the greatest harm to the objectives that I set out? And there are lots of interesting emerging risk assessment methodologies, one particular from UNDP that is very, very good at sort of identifying and working in a multi-stakeholder way to find out which types of corruption are most likely to happen and cause the greatest harms to health sector objectives. The reason this paradigm shift is necessary, and I think it provides certain value, is because of the, let's say, historical desire to push a zero tolerance approach, which I think on paper and certainly as a commitment has relevance and is valid. However, there are lots of aspects, especially in the health sector, where I believe that the zero tolerance approach is perhaps less fit for purpose. And this is because corruption can actually contribute to better healthcare outcomes. So if the difference between a healthcare provider staying in their position versus leaving the country, or, and I'll speak to that in just a second, or leaving their profession, if taking bribes, which I'm not condoning, but if taking bribes ensures that there is a system at all, that there is provision, care provision at all, then it can actually contribute to ensuring that patients do see a provider. It can also be the case that corruption can reduce brain drain. So because an individual is able to receive rents, which again, I'm not condoning, but it might in fact prevent them from leaving their country to go work somewhere else where they have a higher wage. Stamping out all corruption, or the intention to stamp out all corruption by adding financial management approaches, or by increasing the burden of reporting, can actually lead to unnecessary administrative burdens, which incentivizes people to cut corners. And this is something that I'm seeing through one of my researches that I'm currently doing in Maldives, whereby we're seeing that there's so much added regulation to the country that people are just overwhelmed and they don't know what to do because it changes all the time, and it just increases the level of burden, and it incentivizes people to say, okay, well, I have to work around this because it's just too much. And another problem with the zero tolerance approach is that it can actually prevent the development and support of local organizations. So if we're adding administrative burden, for example, on civil society organizations, or even small health posts, it can actually prevent them from having being developed and reaching their potential. So again, I think there is a value in the zero tolerance approach from the perspective that it is sort of a nice commitment, but I think that there are many, these are aspects that need to be considered when we sort of push for having more regulation, for example. And I just wanted to highlight this research that has come from a colleague of mine, Dr. Alina Minju, PPD, here in Berlin, where she has been able to empirically describe or underpin that having increased amounts of policy to and regulation and things like that does not actually translate into a control of corruption. And I've highlighted here Germany, where I am based today, and for you in Indonesia, you can see that it seems like Indonesia has quite a lot of infrastructure with regards to anti-corruption, which of course is commendable and sure, very wonderful. Germany has significantly less. However, we see that the control of corruption is very different. So this is just to sort of highlight that an increase in regulatory documents and policies and things will not necessarily add to the control of corruption. So the final thing I wanted to speak to you today is on the remedial strategies and recommendations for the issue of falsified medical products. Now, considering what we have just reviewed with regards to how should we go about doing good anti-corruption. Of course, usually functions on the prevent, detect, respond sort of circular here. I've highlighted a few of the remedial strategies and recommendations that one can apply. And there are many more that are included in the publication that I described earlier and will share with you. But I'd like to just highlight these few. So first and foremostly, we need to understand falsified medical products in order to prevent them from happening. We need to get a sense of how much of a problem is this in our country or region, in order to be able to then determine what types of responses are appropriate, where is it happening, who is sort of facilitating it, etc. There's a lot of value to be had in raising awareness and training, particularly healthcare professionals at the front line. WHO research found that only 12% of all reports of falsified medical products actually come from the sort of front line, from either patients or providers. And I think that there's something more to be done there. There's a lot of confusion. I think it's increasing, it's improving, but I think there's still a lot that we can do. And the combination of research and training would go a long way. There's a need to increase the regulatory financing and expansion of the mandate, I think, is also very important. A regulatory authority might be well financed, but if they don't have the mandate, which I think was mentioned earlier, that the regulation in Indonesia had been relaxed, for example, that means the mandate changed. And of course, then you're not going to be able to get as much out of that with regards to that particular issue from the regulatory authority. So expanding the mandate to include falsified medical products in a very meaningful way can be very helpful. Then, and I think this is particularly relevant and especially at the level of ASEAN or perhaps Indonesia as a key stakeholder on the steering committee of the WHO member state mechanism on substandard and falsified medical products, to advocate for strengthening cross-border countermeasures and coordination in this area. And then the final point, and this is less of a introducing new regulation, but rather reforming regulation to fit more FMP facilitative policies. So one's tweaking legislation, tweaking regulatory frameworks to actually include falsified medical products, and particularly tweaking sanctions to really address and to really sort of instill fear or reason to reduce the amount of activity in this area by those who are perpetrating it. So just as an example, in France, if you get caught with falsified medical products, the consequence is 1 year of prison maximum and 750,000 euro fine. Whereas if you get caught with narcotics, it's 7,500,000 euros and a 10-year prison sentence. So you can see that it's out of balance. And one could arguably say that, yes, narcotics, certainly problematic. Falsified medical products, at least just as problematic, if potentially not more, because as a patient, you're expecting a product that will do you no harm. So again, these are just a few of the remedial strategies and recommendations that we have to derive from this research. There's more to be found in the report. And I'm very happy to answer any questions that you have. So on that, terima kasih, and thank you again to UNODC for having me, and I look forward to your questions.
Terima kasih banyak, Sarah. Menarik sekali paparannya.
Thank you very much, Sarah. Very interesting presentation.
The problem of zero tolerance, because maaf, saya harusnya berbahasa Indonesia. Itu merupakan pernyataan yang sangat
So that's actually a very intriguing statement that apparently zero tolerance principle can actually bring something that is not right. I noted several important points that it is time for us to use a new lens to find new ways to prevent corruption. That apparently corruption management and control can oftentimes cause excessive administrative burden, which at the end of the day incentivize corruption. Thank you very much for your insight, Sarah. I think now we've passed the allocated time, but I would like to extend this for another 20 minutes, just a little bit. I received 4 questions in the Q&A box, but I can summarize the question into 2 questions. One question is from Mr. Joni Aritonang on whether from the Ministry of Health side have conducted any evaluation, and if or whether they have conducted or taken any mitigation efforts or plan for mitigation efforts for future pandemics. For instance, Pak Joni gave an example of the use of or the domestic vaccine production or use of big data for monitoring and oversight. Maybe Ibu Murti can answer the question, while for big data can be answered by Mas Kunto. The second question is about correlation between governance in healthcare sector with efforts to mitigate fraud or fraudulent behavior. So I would like to ask Bu Murti to answer the first question, Pak Kunto on big data, and Pak Randi to answer the second question. And I also would like to ask Sarah and Agus to answer the same question. Thank you very much. Putri, can you hear me? Yeah. So Pak Joni's question on how, do we have plan to we have planned for future pandemic, including the Omicron variant. So how to anticipate this? We have conducted several meetings, including with the minister from South Africa, from German, which has also seen an increase in Omicron cases. We have also make our border management stricter, and so far we do not have any Omicron case in Indonesia. Interesting question from Pak Joni on sorry, I think this is Mr. Dwi Cahyono about anti-corruption effort. Basically, the question is, what is the correlation between governance and efforts to mitigate fraudulent behaviors? So basically, everything that we want to procure has to have a distribution license, and we will prioritize e-catalog procurement. For instance, in the past, we opened an emergency hospital in Galang Island. So we wanted to quarantine the migrant workers in Galang Island at that time. We also use e-catalog to procure all the health medical devices. So we in Secretariat General provide the recommendation. As long as the e-catalog or the goods and services is available in e-catalog, then it should be procured through e-catalog. In the beginning of 2020, we know that LKPP relaxed the regulation significantly, because they also understand that we need to react very quickly, and at that we need PPE, while PPE vendors in e-catalog were not that much. That's why LKPP at that time allow us to procure with direct appointment method. But again, we need to make sure that all of the PPE are licensed. even our recommendation, one of the recommendation that we have was criticized for not having any license. So I asked my colleagues in the technical department to prepare like the guidelines on which type of PPE should be used for which activity. At that time, we even asked like people conducting regular house visit using full PPE because we were very scared. But now we have learned there are many studies and researches and of course the need of PPE for healthcare workers working in first level clinic is different from healthcare workers working in the ICU units. And for direct appointment, we collaborate with colleagues at LKPP to set the fair price of the PPE. At that time, we did not have a big PPE industry, and only after May, all the garments industry established a PPE production unit. But when we do direct appointment, prior to payment, we will actually check the price. We also invited colleagues from KPK and from the AGOs to make sure that there is no fraudulent behavior. So we are still being careful. In relation to big data, I'm sorry, I was reading the Q&A, but I still don't really understand about what he means by big data. But I really agree. In principle, I agree with the resource person from the civil society. I forgot his name. Agus. Transparency and openness is important. And Johnny said that big data openness, that's very important. That's why no matter what, we will still minimizing procurement using a relaxed system or relaxed procedure. And we continuously assess how urgent is the procurement because we don't want to make any mistake in procurement. Hopefully this answer Pak Johnny's and Pak Cahyo's question.
Terima kasih banyak Bu Murti, memang keadaan yang unik ya Bu selama pandemi saat keputusan harus dilakukan saat itu juga dengan segala keterbatasan informasi yang ada.
So if you have to make decision at that time with all the limitations, that's not easy.
Mungkin sistem yang kita saat ini ada harusnya pada saat pandemi itu bisa kita langsung.
But I believe that the system, our system should be pandemic proof, should be ready to use during the pandemic. But since we are still in a process, I think we can just hope that we can learn a lot from this pandemic. Kunto, maybe you can also help to answer about big data, because I know that in KPK, there's a plan or there's a process of developing big data now? Kunto, please answer the 4 questions. So I would like to answer the first question from Dwi Cahyo Kurniawan. If we read the corruption risk assessment, there is one aspect called objective decision-making process, including discretion. During the pandemic, there are many decisions that need to be taken urgently. So maybe there is no regulation concerning it, but we need to make a decision. So in the corruption risk assessment, it is stated that if the discretion is too much, then it will make the decision makers difficult to make decision. But if it is too relaxed, there can be a risk of misuse or abuse of authority. So in pandemic situation like now, good decision making discretion should be transparent and accountable. So that's the key: transparency and accountability. So whoever made the decision can be held accountable for by other parties or that conduct the monitoring and supervision. That's why we need to build a governance system to reduce bad decision making. But for us, this is as law enforcement agency, whatever the decision, whatever the discretion, as long as they don't have the criminal mind or criminal intention, we cannot prosecute them. We can impose administrative sanction against them, and it can be rectified with the after we have audit from BPKP. They can return the state loss back to the state treasury. But what we want to do is we want to prevent the crime. The distinction now is the criminal intention. If they actually have any intention to conduct conspiracy or to conduct self-enrichment, that's actually the criminal intention which can be prosecuted. Other than that, if you make any decision without any criminal intention, if there is no intention for self-enrichment, but it is an honest mistake, I think this is actually something normal because this is a new situation. It's the pandemic is new to everyone. As long as there is no criminal intention, it can be rectified using administrative measures. Therefore, we need to instill sense of integrity among the personnel so that they do not have any plan or any intention to use this pandemic as an opportunity to corrupt. Big data, with regards to big data, COVID-19 actually posed another set of challenge in terms of data collection. For instance, when the Ministry of Health want to provide incentive to the health workers, apparently they found that their data is not ready. The database is not ready. But after the pandemic, when the Ministry of Health require all the recipient of the incentive to be included in the database, it actually incentivized the healthcare facilities to input the data of their healthcare workers under them, because otherwise the incentives of those healthcare workers cannot be dispersed. So this is an important as well as a very good opportunity, something that should be built even in the past. For instance, and this is also true for data on facilities owned by healthcare our medical facilities. Now all the medical facilities are also very keen to increase or complete their data, because the government used this to monitor the availability of beds, hospital beds. So the problem in Indonesia nowadays, when it comes to data information, is on data input. Most of us have good application. It's just that there is no consistency in data input. For instance, for criminal cases, we have the database. In court rulings, we also have the database. However, the data in those applications are not updated because there is no there's no legal instruments that compel people to input the data consistently. So basically, this is a homework for us to improve on the quality and availability of data in Indonesia. But we see that COVID-19 has made many agencies use data more and also input data more, so that the decision makers can make better decision using the available data. Thank you very much, Kunto. Thank you very much, Kunto. Indeed, this is something that people often question. Whether whenever there is any state laws, then the person can be prosecuted. But I agree with you that we have to be able to prove that there is any criminal intention before prosecuting the person. I see that Pak Collie is raising his hand. I would like to ask the three presenters to hold your answer so that we can hear from Collie, and you can maybe respond to his statement.
No, thank you very much. I just wanted to appreciate the presentations that have been made. Very, very interesting. Sarah, if I can circle back to you for a minute. I listened with interest. The presentation thought very, very, very comprehensive. One point that I wanted to revisit, if I can, is the issue of zero tolerance. Because I think for a lot of people, it's an expression that can be construed in several different ways, right? So, from the general attitude that corruption should be considered intolerable to, or high priority to the uncompromising policy, which says under no circumstances, in terms of what does it really mean. And I'm just wondering whether or not you can circle back to that a little bit for me and put that in some further context. Because I think there are debates on both sides, even in terms of the benefits or not of zero tolerance. Clearly, the issues of cost related to it, as Putri had made reference, and as yourself had made reference to, is one that ought to be considered, right? So you have instances where if a project, and if we're talking about infrastructure project, for example, roads and other kinds of high cost infrastructure project, where a zero tolerance policy may be applied that says if there was any corrupt practices, then that whole contract gets canceled, right? Obviously, we can understand and appreciate the high costs that may go with that, especially when you have subcontractors who may not have anything to do with anything and may not even know what may have happened. But in the sense of when we talk about zero tolerance, if you can, it would be, I certainly would love if you can circle back to that a little bit and put that in some more context, considering some variation around the term itself. So thank you. Over to you.
Thank you very much, Collie. Shall I go ahead, Ibu Putri?
You want to go ahead? Okay. So Ibu Sarah dulu, lalu Bapak Randi dan Mas Agus.
And then Randi and Agus.
Okay.
Please, Sarah.
Terima kasih. So thank you for the comment there, Collie. I think you're very good to call me out on it. I think it is certainly a perhaps provocative thing to say, certainly in a forum like this. I can say things like this as an independent consultant. I think that I would actually say that I don't know that it's either or, that it's either zero tolerance or you have tolerance. I think both can exist, that we have sort of this understanding that zero tolerance as an ambition is appropriate. However, in practice, as you mentioned with this infrastructure project, it may not actually be fit for purpose, because the question is, do we, and I think when it comes to certain sectors, and we talk about improving health outcomes, I think that there may be, and with regards to the overall aims, what are we trying to achieve? And if we are trying to achieve better health outcomes, but we are focusing our anti-corruption efforts on counting or having records of all the receipts, of everything, all the money that was spent, and we have a wonderful bookkeeping system, but we don't actually improve the health outcomes, then yes, on paper, we've succeeded in anti-corruption because we have a wonderful bookkeeping system that has collected all the receipts and we know where all the money went, but we didn't actually meet our goals. And so I think it's not necessarily of saying throw away the zero tolerance approach, but it's more saying, okay, there's a rhetoric in there that is important from a moral standpoint, an ethical standpoint, particularly with regards to health. But from a practice standpoint, we need to be thinking more preventatively. We need to be thinking more objectives-oriented, outcome impact-oriented, as opposed to counting receipts and things like that. I think it really lends itself well and aligns well with the results-based financing approach, which of course, empirically has had positive, but also less positive results. But I hope that sort of provides a bit of additional context. I'm not saying, as I said, to throw out zero tolerance. I think that it has merit as a rhetoric. However, I think in practice, we need to be more agile. And I think it speaks a bit to also what Kunto was saying with regards to sanctions. It's very difficult to find criminal intent. And so when it comes to zero tolerance approach, we can say, yes, we'll aim to sanction. But if we can't find criminal intent, then what do we do? So I think by going away from the zero tolerance approach, taking on more of a mainstreaming approach, we actually find ourselves doing anti-corruption in a public health way, where we are prioritizing prevention and detection over and above sort of maybe what might be what we do otherwise, is where we cut programs and look for people to take to court.
Oke, thank you, Sarah. Mungkin saya akan mencoba mencari
I will try to find the theme line or the red line that corruption management should not prevent us from achieving the ultimate goals of health governance, which is to deliver best quality healthcare. So whatever governance, control, corruption prevention measures that we have in place should not be overly strict. It has to be flexible enough so that we can still achieve the ultimate goal of healthcare sector. But at the same time, we need to maintain transparency and accountability, because this is actually our common responsibilities. So hopefully this conclusion is actually correct enough, Sarah. Now I would like to invite Randi to respond. But I have one more question in the Q&A column about fair price, a mechanism to set the fair price. But I think this question can be kept for last and can be directed to Murti. But now I would like to invite Randi and Agus to answer the questions, the two previous questions. What was the question again, Putri? Okay, the question was about correlation between governance and efforts to prevent fraudulent behaviors. Okay, I can answer it like this. For health, for medical devices, including drugs, medicines, vaccines, in that we call that we know as regulated business, which means that we have to follow certain set of regulatory standards. In the US, you have USMDA. In Europe, you CMARC. And in Indonesia, we have Food and Drugs Agency for food, cosmetics, and drugs, while for medical devices, we have the Ministry of Health. So that regulatory standards is to ensure quality, performance, and availability. So that's the ultimate goals, to provide sense of security as well as good quality healthcare to the public. So automatically, the governance should be good. We need to have good governance from upstream to the main to the downstream. From production, the product should be produced in good good manufacturing practices, which we translate into Indonesian good manufacturing practices. And then we need to have good distribution practice. In Indonesia, we translate it into Indonesian good distribution practices, so that the manufacturer produce good products, the distributors distribute and transport it in a good way, so that the products can reach the consumer in a good state, which means at the same time, the procurement should also be good, so that the quality is not being undermined. Sarah mentioned that the raw material should be in high quality, because otherwise the result will be substandard. We want to make sure there is no falsified product. And in Indonesian context, we also have law on healthcare to guarantee healthcare services. And we also have fines and penalties that can be imposed to various parties to ensure that the medical devices and supplies used by the patients are in good condition. And we from association since 2017 or 2018 have adopted have joined KPK Profit Professional with Integrity program. So we encourage our members to have good professionalism and good integrity, because aside from this, aside from being regulated, we are talking about the life of people. One day, those products can be used by our family members, our wives, our children. So there is a set of higher ethical standards. So we have special DNA here. So quality, security, performance, and accessibility, including affordability. For our members, later I can explain about our price structure. So we have a mechanism to set the price. And to answer the question about fair price, I want to ask, what is the intention of the question? Are we talking about fair price from distributor to hospital, or the price applied to the patient? So that's my response. Thank you, Putri.
Ini kita udah lewat waktu panjang, tapi diskusi
Thank you. This is an amazing discussion that we have. I would like to give the floor to Bapak Agus to answer these two questions on the mitigation effort and also the alternative to prevent
data itu.
Fraud or corruption. Mas Agus? Thank you, Putri. I think the key word here is transparency and accountability. These are the two keywords to answer your questions. We believe that in principle, society would want to monitor if they can have access to information. The problem is we can't find that many information. Second is the big data system that is integrated. Since the beginning, we encourage, like what Bapak Kunto stated, we want to avoid the duplication of procurement. For example, the national government already have a PPE procurement and distributed to one of the provinces, say in Yogyakarta. But the need in Yogyakarta is 1 million PPE. But at the same time, the Jogja regional government also do the procurement for the 1 million PPE. This is a real problem, a possible problem, if we do not have a good big data system. The COVID-19 pandemic opens our eyes that we have data problem, be it on our social data or health data. And I think in the context of this pandemic, this should be used as an opportunity for us to improve our data quality, our social data, our health data. We do not want the next pandemic to happen, but if that happens, then we are ready. And the health sector is ready, the health sector is ready. We highly appreciate that in the beginning, there is a system to check the bed occupancy ratio. And if you remember when there was an increase of Delta variant, the CSO movement in Indonesia was amazing. The people participate to contribute to a pool of information, so people would be able to see where they can get oxygen, for example. When public participation is high, there are a lot of good benefits. And imagine if all of this are integrated. They can check, for example, where they can buy medicine, which pharmacy closest to them. Of course, we do not want the number of cases to increase again, but we see that the fraud potential can be addressed if we can have a good transparency. ICW and us, we found difficulty to find out, for example, what is the total number of PPE procured or testing tools procured, antigen test or the rapid test, for example, and PCR. We wanted to obtain such information because we wanted to calculate and compare it with the budget for that particular spending. So, Ibu Putri, the key is transparency and accountability, and also to provide CSO to do monitoring. That will be all for me. Thank you. Thank you, Bapak Agus. Sarah, is there anything that you would like to respond to other speakers' statement? On the connection between the management to mitigate corruption and also the opportunity to use technology to prevent corruption. Sarah?
Thank you, Putri. So yes, I think rather than, so the question, it sounded to me like the correlation between management and efforts to mitigate corruption. But I would say that what we've seen from the pandemic is more that there are many, many examples of what is going wrong in systems, what is going wrong in health systems. So rather than what is the correlation between sort of management and positive outcomes, what we see more is what is the correlation between a failure to prioritize corruption and the outcome that corruption occurs. And I think to Agus's point that we need transparency of data, we need or to say that we need to be, we're identifying through the pandemic the gaps in the system where we need to make improvements. So his point was that we need increased transparency of data in a usable form so that civil society and regular citizens can use this data to hold their leadership accountable. So I don't know that we have empirical or founded evidence of good management leading to good anti-corruption. We've seen procurement scandals across the world, high-income countries, low-income countries, middle-income countries. It's happening everywhere. But what we are seeing is that if we listen well enough to civil society organizations, to members of the private sector, to the national anti-corruption commissions, they're calling for improvements. And I think that that is what we need to now listen to, as opposed to look for sort of islands of integrity or instances where a certain anti-corruption or governance mechanism functioned. We need to listen to those who are actually trying to address the foundational problems and what they require. So I think that would be my advocacy going forward.
Terima kasih banyak, Sarah. Baik, ini.
Thank you, Sarah. Thank you so much. This is already 5:54 p.m. I would like to apologize that we are running later than what was scheduled. And Ibu Murti, I am sure that the question on how we can get a fair, reasonable price, Bapak Harfana.
Mengundang narasumber mungkin yang bisa menyampaikan menjawab lebih baik lagi mengenai kewajiban.
Who asked this question?
Sampai di sini saya.
This is, I think that question can be discussed in a different forum. I would like to say thank you to all our panelists, to all our speakers who have taken the time to join our event. It is amazing to listen to the presentation from all of you and to see the progress that we have made. I would like to say thank you to all the panelists. I would like to say thank you. One more thing, Bapak Randi, thank you so much for the honesty in giving feedback and also sharing the lessons learned. And I would like to say thank you to all the participants for joining us. I'm sure that the discussion, I'm sure that all of us find the discussion very interesting. But before I close this event, I noted 4 important points from our discussion. Number 1 is that it is very important for us to do collaboration and also to have good communication among important shareholders, such as government, academician, and also private sectors in preventing corruption. Second, public participation is needed. It is an important aspect, and we can say that this is a disruption mechanism to ensure that transparency can be optimized. Third is the use of technology. The use of technology, I'm sure, as we have heard before, the open data, in budgeting and all other aspects can positively contribute to monitoring and also increasing transparency and accountability. Last, the importance of strengthening capacity in public and private sector to keep on adapting and to be agile. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. I hereby close this webinar. Thank you so much. Have a good day.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Pak Kunto, Pak Randi, Bu Murti, terima kasih banyak.
Bu Murti, terima kasih banyak.
Bu Sarah, terima kasih banyak.
Terima kasih
banyak.
Thank
Kunto,
you.
terima kasih Pak Kunto.
Ya,
Thank you,
sama-sama, Pak.
Putri. Very good job.
Thank you, Pak
Yes.
Collie.
Colin, thank
Thanks,
you.
everybody.
Sarah.
Bye-bye.
Bye-bye.
Kunto, nanti saya kontak ya Pak. Kita mau ada event nih Pak.
Yes, ya.
Ya,
Kita mau
Iya.
bikin training Pak Kunto. Teman-teman saya semua mau bikin training untuk pemantauan pengadaan vaksin Pak.
Siap, Pak. Siap.
Siap.
mantap.
Iya, siap.
Mas Agus
Siap.
menanyakan pada pihak yang tepat.
Udah sering diskusi kita, Pak.
Udah cukup sering sih Mbak. Nah
Iya.
ini follow up dari beberapa rangkaian diskusi.
Iya.
Insya Allah tanggal 16 atau tanggal 17 ya Pak Kunto?
Ya, siap, Mas.
Siap. Makasih Pak
Iya.
Kunto.
Siap.
Ya,
Mbak Putri,
Terima
saya
kasih banyak.
izin ya.
Ya,
Makasih.
Ya,
izin
terima
live
kasih
ya.
banyak Mas Kunto.
Salam.
Makasih banyak.
Ya,
Makasih banyak
sama-sama.
Mas Agus. Terima kasih banyak atas bantuan interpreter dan seluruh kru yang ada di room ini. Terima kasih banyak. Terima kasih banyak Pak John, Mbak Yuyu, Mbak Wijay, siapa lagi ya? Terima kasih banyak ya.